Assalamu alaikum viewers. We will be discussing with you today the what you can say Glinides, Biguanides, and thizolidonediones. We may also give a touch to the gliptins, and remember some of them are given through the subcutaneous injection like incretin, like peptides. The rest of them are oral hypoglycemic agents. So we will be focusing some Biguanides and thizolidonedione derivatives as oral hypoglycemic agent. So these are the objectives, and here we have focused the Glinides and Biguanides. Glinides, you see, in the last lecture we have talked about the sulfonylureas, which were classified as class 1B, class 1A, and this is a potassium channel modulators. So you see, it is not a sulfonylurea, but acts like sulfonylurea, and it acts at the especially at the postprandial level when the blood glucose shoot up is there. So it's going to regulate this postprandial shoot up, and this postprandial shoot up, you see, in this particular cases, you see, this drug can be very helpful in the management of postprandial shoot up. Usually people say, if you do not eat, do not treat, because when you are not going to eat, so there will be no postprandial shoot up. So these drugs are good drugs and may be used as in combination with the other or anti-diabetic drugs. Metabolism is 90% to the level, so care should be taken to prescribe this to patients suffering from hepatitis, and 10% is eliminated by the kidneys. Therefore, it's not a problem unless there is severely your patient is renally impaired. The advantage is that it has a less chance compared to sulfonylurea. It has a less frequency of hypoglycemia, and weight gain is relatively less as compared to sulfonylurea with this class of drugs. So therefore, they are also called as fashionable drugs as well, like Metformin. Regarding Glinides, so far the contraindication are concerned. In case of type 1 diabetes mellitus, we cannot give it because the pancreas is not working, and as I said, in case of liver cirrhosis or severe liver problems, you see, we shall avoid in using these types of drugs. Drug interaction, when the metabolism is maybe enhanced in case of enzyme inducers, and the metabolism of this drug may be prolonged or decreased, mean the blood glucose level of this glinides will be increased if it is used in the presence of another drugs which will inhibit the enzyme, especially at the liver. Thus the metabolism is slowed down. So care should be taken when you are going to use enzyme inhibitors or with enzyme inducers. These are the dosages, and as I said, no eat, so therefore no need to treat, and these drugs may be used as in combination. The other class is incretin, mimetic, and related drugs, exenatides, you see, and the mechanism of action is, it is a peptide, incretin, you see, mimetic, like glucagon, like peptide, and this is 5 to 6 times, you see, this is more active in especially resistant cases, commonly known as glucagon like peptide 1 receptors agonists, or they are also called as GLP-1 analogs, and they are normally prescribed for the management of diabetes mellitus. They are insulin secretion secretagogue, you see, and the most important one is that the proliferation of beta cells, B cells, is increased. This could be helpful, especially in the synthesis of B cells as well, and which could be helpful in the further deteriorating the pancreas, especially if concomitant tissue necrosis or degeneration is there. So these drugs can be helpful as well. They decrease the glucagon secretion, and perhaps this will help in the hepatic production of glucose. So gluconeogenesis is decreased. Since the gastric time is decreased, and further there is satiety effect is increased, so appetite is decreased. Consequently, weight loss will be there for this class of drugs. And this class of drugs, you see, these are used in United States of America with these trade names. And the most important one indication is either it is used alone or in combination with metformin or sulfonylurea or sometimes with insulin, especially when the insulin dose is increased more than 100 units per day, or insulin resistance diabetes mellitus. Side effects is usually nausea, anorexia, and vomiting, you see, and diarrhea may be there. Hypoglycemia especially is there, but it is not as strengthful as it is with sulfonylurea. One should be careful about the pancreatitis and hypersensitivity reaction as well. Incretins regarding exenatides, you see, the contraindication is has pancreatitis, hypersensitivity reaction, and GI disturbances, renal impairment. If it is severely renal impaired, mean that the creatinine clearance rate is less than 30 ml per minute. It's also medullary thyroid carcinoma is if there are multiple endocrine neoplasia type 2, especially men's type 2 is there, so you cannot give this class of drugs. There may be regarding drug interaction, hypoglycemia with other oral anti-diabetic drugs or with sulfonylureas, and these are they are usually used as monotherapy or in combination with other therapy. They are very good drugs in obese because it mobilizes that decreases the fatty acid production as well, and hence these drugs can be very helpful in the management of patients suffering from type 2 diabetes mellitus along with obesity. Other is class of drug is gliptins, dipeptidyl peptidase 4 inhibitors, and is sitagliptin, vildagliptin, sextagliptin. You see, the mechanism of action is that gastric inhibitory polypeptide and glucagon-like polypeptide, as they are secreted primarily from the wall of the intestine. You see, and upon the ingestion of a glucose-rich food or glucose, so it stimulates the secretion of insulin from the working pancreas, mean the beta cells of the pancreas. The action is reversible, and remember this incretin hormones, especially in gastric inhibitory polypeptide and glucagon-like peptides, you see, they increase the insulin secretions and decreasing the glucagon secretion as well. I mean, gluconeogenesis is also decreased with this class of drugs, and sitagliptin is usually administered orally but eliminated 80% to the kidneys and 20% to the liver. Therefore, care should be taken while prescribing this class of drugs to a renally impaired patient. Adverse effects include lymphocyte level is decreased, lymphopenia, and the risk of infection, especially nasopharyngitis. That is especially with this class of drugs. Especially in this COVID pandemic, care shall be taken, especially if you are going to prescribe gliptins and your patient is maybe prone to nasopharyngitis as well, sinusitis, and of course sometimes urinary tract infection as well. So so far the GIT profile is concerned, it is associated with less incidence of nausea and hypoglycemia. You see, alone is chances are a bit rare. So these are very good class of drugs. Especially, what are the contraindication? Hypersensitivity, drug interactions with cytochrome P450, especially if the enzyme is inhibited or enzyme inhibitors are there or inducer are there, then it can create a problem for you. The plasma level will be shifted, and once the plasma level is shifted, then either the drug performance will be increased or decreased, as the case may be. So in case of enzyme inhibitors, you see, so the plasma level will be increased and the hypoglycemic effect will be also increased. And in case of enzyme inducer, the plasma level of the drug will be decreased and the hypoglycemic effect will also be decreased. There may be a risk of hypoglycemia, especially associated when you combine with other class of antidiabetic therapy. The other class is you see, insulin sensitizer, and remember it does not produce hypoglycemia in euglycemics. And the class 1, 2A example is Biguanides, Metformin, and Metformin. And remember, it's pharmacokinetic that it is well absorbed through the old routes. 60% is absorbed through the GIT. It's not so much as it should be. It's not plasma protein binded drugs, and it's not metabolized especially, and consequently, it is entirely secreted by the kidney, partly by the pertubular secretions. You see, and then it may increase the level of other drugs which are secreted through some of the sulfonylurea. If it is combined with sulfonylurea, so the level of the sulfonylurea may be increased. So it may potentiate the hypoglycemic effect of sulfonylurea if it is combined with sulfonylurea. Now this is a point that is to be considered in mind, and especially once it is absorbed, it is distributed to the liver and other body portion, body fluid. And most important aspect of this class of drugs is that it is excreted by organic cationic transporters. You see OCT1, 2 and OCT1, 1 and OCT1, 2. And the body, this clearance of this drug is through this organic cationic transporter. This is very important, especially when your patient will be suffering from a genetic profile shift. So the response of the drug may be changed in one patient from patient to patient with a shift in the or change in the genetic polymorphism. You see, so some care shall be taken in mind when you are going to prescribe metformin to a genetically mutant person, where this OCT1 and OCT2 transporter mechanism are changed or mutated, so it will not properly work. Either plasma level will be increased, or the body will get rid of its early and its plasma level will be decreased, or as the case may be. So they are very safe, high therapeutic index, you see, and therefore up to 2550, meaning 3 grams per day with meal. These drugs are very safe. Mechanism of action of this metformin is small, that it has complex number one in the mitochondria, decreasing the ATP, and you see the AMP level is increased, and once the AMP level is increased, so it increases the AMP activated protein kinase enzyme, and consequently the acetyl-CoA carboxylase function is decreased, and thus the lipid synthesis is decreased, the hepatic lipid production is decreased, and gluconeogenesis is decreased, and therefore this class of drugs is working not on pancreas, but rather the utilization of the glucose is also increased at the cellular level. The pharmacological effect is that most important is that decreasing the glucose output production, glycogenolysis, you see, and decrease the glucose output consequently. So important point is that the hepatic gluconeogenesis is also decreased, and this class of drug can be very helpful, especially in obese and those who have already a fatty mass, especially in their muscles, you see, and therefore these class of drugs are very helpful in the management of weight reduction as well. So peripheral glucose uptake, you see, especially through the GLUT1 and GLUT4 transporter system, anaerobic pathway is increased, and this will lead to lactic acid production, and lactic acidosis will be there, or metabolic acidosis, you see, will be there, and therefore one should be very careful in treating a patient being already managed of diabetic ketoacidosis, and once you are going to put him again on metformin, so try to avoid this particular patient who has already been exposed to diabetic ketoacidosis being managed, and you are now discharging them on oral anti-diabetic drugs. So insulin sensitivity to binding to receptor is increased, and therefore this class of drugs are very helpful in the management of insulin-resistant diabetes mellitus. Consequently, these class of drugs are also prescribed concomitantly with insulin, especially to patients which require higher doses of insulin, or if they are obese, So just prescribe the metformin. The most important thing about metformin, as I told you in the class, that time adjustment shall be there. That once your patient is going to walk and the plasma level, you see the peak level of drug. The peak level of drug is if it is 1 hour, 2 hour, the peak plasma level of the metformin CP max is there. You see, so and this is T max. So try to take metformin drug. Advise them metformin before 1 hour, 1 hour before walk. There is no risk of hypoglycemia with metformin, especially. Uh, so even if your patient goes to euglycemic condition as well. So one should be quite vigilant about this. That sometimes the patient exercise, but the timing is not regulated. So better is that your patient shall exercise, go to exercise when the CP max in the time, the plasma concentration is at maximum level, as you see following the administration of metformin. If it is not being taken, then you see the drug will not work as it is expected to be. So synergistic effect of exercise, physical work, exertion, once combined at the Tmax with the metformin, that has produced dramatic results in the regulation, peripheral utilization of glucose and glucose homeostasis. They decrease triglyceride level, they also increase the HDL, which is required. Therefore, patient with having a history of uh, uh, with hyperglyceridemia or distorted lipid profile, one shall advise metformin because it's going to regulate the plasma lipid levels, and at the same time it is improving the lipid profile and blood glucose profile as well. So some clinical effects, you see, metformin is used for which? They are used for the type 2 therapeutic, type 2 diabetes mellitus, for the treatment of type 2 diabetes mellitus. These are the off-label use of metformin. Usually it is also in some UCMLE exam or any other exam. So these are off-label use, especially gestational diabetes, polycystic ovary syndrome, prevention of weight gain, you see, reduces the risk of some cancers, especially, and that is pancreatic cancer, you see, and help to reduce the LDL and increase the HDL, and cholesterol level is optimized. And if your patient is suffering from triglyceride level, increased triglyceride level, so it is optimized or normalized. And these are the side effects. It suppress appetites, so weight gain is not there with metformin, and since metabolic acidosis is there, and therefore you should be quite vigilant about using these drugs with a patient who is already suffering from diabetic cutic cirrhosis and being managed, and now you are shifting to oral antidiabetic drug as I referred to earlier. Contraindications, and elderly patient, and also drugs that interfere with ketonic drug transporter system, you see, as I discussed earlier. So therefore, this class of drugs may interfere with the elimination of metformin from the body. The glitazones, the other class is the 2B glitazones, and molecular mechanism of glitazone is that it binds to the nuclear receptors that is present especially in the adipocytes, muscle, liver, and remember the gene transcription, especially that the insulin responsive genes, synthesis of new protein that is improved, uh, uh, and once it is improved, so the insulin sensitivity is improved. How? By number first, that is adipocyte differentiation and proliferation is there, and it leads to the lipogenesis and this apoptosis of the large fat cells and increasing the number of small cells. This is associated with the increased fatty acid uptake and decreasing the circulating free fatty acid and decrease the lipotoxicity in liver and muscles as well as in the B cells of the pancreas. So important factor that is that decreasing the release of inflammatory mediated tissue necrotizing factor and inflammatory IL-6 inflammatory leukocyte and interleukin 6, you see. So So this insulin resistance is decreased, and the free fatty acid or the fatty acid release is also decreased, and this is because of the increase in the adiponectin, which is associated with the inverse relation with the leptins and resistin as well. So thus these drugs optimizes the insulin resistance diabetes mellitus by once it is combined with insulin or or other oral anti-diabetic drugs, especially the insulin entropic drugs. Uh, they also increase the uh, AMP activated protein kinase in liver adipose tissues, thus the glucose free fatty acid level that will be decreased, and consequently this will optimize or manage the blood glucose level. Its biological effects takes weeks to develop. Why? Because it acts through the synthesis of new proteins, which takes weeks. You see, it's going to increase the adiponectin level, and then adipocyte. You see, when it takes time to generate. So this could be the logical answer to this one. The fatty acid level, especially the insulin resistance cases, you see the glucose that is in the blood that is decreased, and consequently is going to help you in managing relatively resistant cases of diabetes mellitus. It is anti-atherogenic drug, and this can be helpful especially in the fibrinolysis, and endothelial function of the microvessel is also increased, and consequently the microalbuminuria associated with vascular damage at the level of kidney that is decreased. So it decreases the microalbuminuria and increasing uh, the the or optimizing the uh, lipid profile. Thus it manage your patient, especially if he is diabetic and suffering from hyperlipidemia as well concomitantly. Then the 2B class, that is glitazone, glitazone, the mechanism of action for this, they do not promote the insulin release. Remember, this is a technical point to remember. But they increase the insulin sensitivity like that as by Biguanides and Metformin and Metformin. The fat metabolism, increasing the sensitivity of insulin to adipose tissue, uptake of free fatty acids increase, and there is decrease in circulation of the free fatty acid and visceral fat, and of course in the a decrease in the liver fat as well. So for a fatty liver, this class of drug is also a very good, not only to decrease the blood glucose level, but also to have a good prognosis on the fatty liver as well. Regarding muscles, it improves the insulin sensitivity in the muscles and increasing the glucose uptakes, and liver, you see, this inhibits the gluconeogenesis. Regarding pharmacokinetics, it is well absorbed through the oral route, and the peak plasma level reached within 2 hours, and 99% it is plasma protein binding drugs. Remember, it is metabolized usually through the cytochrome 2C8 and 3A4 isozyme, you see. So, and it is usually eliminated in feces through the enterohepatic circulations as well. Biological half-life extends sometimes to 24 hours, therefore once a day dose is to be administered. Regarding efficacy, the total need for insulin by 30%, you see, it is decreasing. It means that it increasing the sensitivity of insulin, especially when your patient requiring higher doses of insulin. For example, a dose more than 100 units per day of insulin is required. You see, so if you combine this drug, so automatically this will be shifted to 70 units. So we are going to decrease the insulin dose. So this class of drugs are very good, especially in insulin resistant diabetes mellitus management. As usual, we discuss improves the triglyceride levels and decreases the free fatty acid levels, and increasing the HDL level. This is very good. And the microvascular complication, you see, you can use this. Prevent the type 2 diabetes mellitus in pre-diabetes patient. So if you receive a pre-diabetic patient, best is to control with diet or exercise, and if it's not controlled, then you go for the glitazone. and it also improves the polycystic ovary disease or syndrome like that of metformin. Fluid retention is there, and sodium and water retention is there, so there may be hemodilution as well, and chances of fracture is increased, especially when there is a fall attack or drop attack with use of glitazones. So care shall be taken about this class of drugs. These are the adverse effects, and as we said, fluid retention, weight gain, anemia, neutropenia, neutrophil level is decreased because of this dilution, as I discussed earlier. Osteopenia may be there, so chances of fracture are there. And take care, especially if you are using a patient, an elderly patient, or we are patient or suffering from chronic or congestive heart failure. So these drugs should be used with cautions. Already, chances of bladder cancer has been increased if the drug is used for more than one year. Regarding 5-glitazone, you see, usually we go for the monotherapy in mild cases, and it can be used in combination with other type 2 diabetes mellitus drugs, you see, and or with the insulin, and this is what we have discussed in the previous slide. So these are the doses, and drug interaction, hypoglycemia with insulin, as we referred to earlier, and some metabolic effect, you see, enzyme inducer and enzyme induction and enzyme inhibition, you see, and then contraindication. So it cannot be given in type 1. Why? Because the pancreas is not working, and the more thing is you have to be vigilant because it's increasing the peripheral utilization of the glucose as well. So pre-existing hepatic disease is there, and you cannot give it severe heart failure, you see, and pre-menopausal anovulate woman, you see, or menopausal syndrome, you have to use this drug with caution. Osteoporosis are at more risk. And as usually, when I use this slide for comparison, just that you shall remember. So insulin secretive guard, they have a prognosis of 1 to 2% reduction HbA1c, and the least one again is alpha group sedase inhibitors. So remember, the medical nutrition therapy is as good as insulin or as sulfonylurea is. So keep in mind, first go for the medical nutrition therapy, then go for the medical nutrition and physical therapy, and then go for the drug therapy. Thank you.